My name is Brian Kopell. I'm the director for the Center of Neuromodulation, and I am a professor of neurosurgery in the Mount Sinai School of Medicine. Today, we're going to discuss some of the misconceptions surrounding deep brain stimulation as a therapy. Misconception number one, DBS is an expensive therapy not covered by insurance. I get this question all the time from patients. The good news is that DBS is a therapy that has been around now for well over 20 years. For most indications, it's completely covered by insurance, and most patients do not see a significant cost. Besides their current copay scheme. For other off-label uses, the insurance coverage can be slightly more difficult to obtain, but our center has been successful in pursuing coverage for some of these other uses with commercial insurance. Second, misconception number two regarding deep brain stimulation surgery, that the surgery is very, very arduous and requires an extensive recovery time. The good news is that DBS as a procedure is a very paragon of minimally invasive brain surgery. 99% of the patients in our practice go home the very next day after undergoing implant DBS surgery. The other aspects of DBS surgery are done as an outpatient surgery. So in essence, most patients have a minimal impact on their normal activities of daily living from undergoing this surgery. Misconception number three regarding deep brain stimulation. DBS is the surgery of last resort. This is perhaps the number one misconception that I encounter in my practice. This couldn't be further from the truth. Because DBS has now been in practice now for 20 plus years, the data from multiple scientific studies are extremely clear that the earlier you intervene with DBS, the greater and more durable improvement in quality of life can be achieved for a particular patient. And that is the most important thing for patients to understand, that this is absolutely not surgery of last resort, that we can do tremendous improvements in quality of life by intervening much earlier in the course of the disease. Misconception number four, DBS is experimental surgery. As I said a little bit earlier in this discussion, DBS now has been around now for almost 4 decades in its current form, or for 4 decades, and in its current form for at least 2 decades. This in no way is an experimental device in any way, shape, or form. However, emerging uses of deep brain stimulation, such as for depression, Alzheimer's disease, stroke recovery, are in fact investigational uses of this device. Currently, DBS is approved in the United States for movement disorders such as Parkinson's disease, essential tremors, and dystonias, as well as medically refractory obsessive compulsive disorder. These are not considered investigational uses. They are considered approved FDA uses of the device. All right. Misconception number 5, my disease is not quote unquote bad enough for DBS. This is a very, very complicated discussion, and it relates to the notion about whether or not DBS should be used as a quote last resort. I want to make it clear again that DBS surgery has been shown by actual scientific data, not by just merely an opinion, that it is not surgery of last resort. And the earlier you intervene with DBS, the greater and more durable improvements in quality of life can be achieved. It is important to note that when patients, the idea about DBS is to maintain a normal quality of life. The longer one waits to allow their disease state to get worse and worse and worse, sometimes permanent changes to a person's overall conditioning can ensue, which makes ultimately regain of function much more difficult. By intervening earlier in the process, one can stave off that end result. So misconception number 6, the batteries require frequent replacement. That depends on a lot of different factors. The average patient gets about 4 years of use out of their batteries. It does require an outpatient short procedure, roughly around 30 minutes, to replace the batteries. However, there are rechargeable batteries that can last up to 15 years. Misconception number 7, DBS requires me, the patient, to be awake in the operating room. Another misconception that I like to erase from patients' minds, if you will. In the earlier days of DBS surgery, we required patients to be awake so that we could record their brain cells and create a physiologic map of their brain. The good news is that imaging of the brain has gotten tremendously better over the last decade, and being awake in the operating room is absolutely no longer required to undergo successful DBS surgery. We have operated on many patients here at Mount Sinai with them being completely asleep and have achieved absolutely equally successful results than in patients that have undergone awake surgery.